Now to the talk of Dr. Sundaresh on management of bone defects and total hip replacement.
Saram to one and all. I'll talk a little about what I have learned with my experience about managing bone deficiencies in THR. Bone deficiencies occur due to many reasons, and we see a lot of bone deficiencies in the acetabular side, in primary, or what we call the complex primary, and the other conditions of trauma, inflammatory arthritis, and others. Of course, revision surgeries will be dealt with later. The Paprosky classification has elaborated what kind of bone deficiencies. I will not go into it because it comes into the ambit of revision surgery. The essential fact is that when you are dealing with bone deficiencies and using an implant into a deficient bone, you need to address the biology as well as the mechanical consideration of the joint as a whole, and only then you will succeed in giving a good implanted prosthesis. Femoral deficiencies can be either metaphyseal deficiencies, a proximal tube deficiencies, or a distal tube deficiencies. With all the things that have been already talked about, one understands that the potential for remodeling of the femur is extremely good, especially if you have addressed primary stability and the biology of the situation in which you are dealing with. A number of prostheses are available, so you need to make a decision as to what type of prosthesis you are going to use in advance, and probably keep all options open when you are dealing with these kind of things, and including bone grafting. The excellent remodeling facility of the proximal femur after you do a revision is very good. And this just to show that a Wagner stem which is put into a 72-year-old male, 8 years after surgery, an ETO and a transfemoral approach has united very well and is given a stable prosthesis. Proximal bone reconstruction may not be possible all the time, even in large bone defects. So this allows that we should ensure distal stabilization, and a cementless version is the choice. The prerequisite for this would be a temporary distal fixation and successful bone modeling, provided you have a good bone stock proximally. Femoral deficiencies, when you're addressing femoral deficiencies, you anticipate potential problems and plan adequate exposure through an ETO. Extract the failed implant effectively and safely with minimum amount of bone loss. Try and avoid taking out more bone. So the method described by Dr. Bose about cutting the femoral stem is something which one needs to keep in mind, because most often we don't have the necessary implements to cut a metal in the operating room now. And avoid complications like commenting the bone fragments which are removing in the ETO or the transfemoral osteotomy. And achieve a firm fixation. When you are finished with the prosthesis, you should have primary stability, and reconstruct the areas of bone loss and correct deformity as necessary. And the rehab program has to be customized to the needs of the patient. Similarly, in the acetabular thing, the Paprosky classification is quite extensive when you are dealing with the 3A and 3B, where you have pelvic discontinuity and severe bone loss in the ischium and the superior part. You need to address it with suitable implants or bone grafts. Uncemented fixation in the acetabulum is the choice, unless you are not able to create a hemisphere where you can't give a press fit. Achieve primary stability one way or the other. And when you're using a uncemented cup, you should have at least 50% bone contact in the acetabulum. Cage fixation is a common thing commonly used for acetabular deficiencies. It's an anti-protrusive device which protects bone graft which you have put underneath, and putting a bone graft underneath to bridge the bone defects is mandatory, because that is what will give you long-term stability and results, especially the medial wall and the roof. The cage acts as a load bypass, and 30% of bone contact must be there for the cage. Otherwise, even the cage will fail, and it prevents migration of the cup and collapse. I'll give you an example of a 9-year-old revision situation where on the right side we had a bicontact hip done with a press fit porous coated cup, and the poly was not a cross-linked poly, and this is the situation in which it was seen. The cup seems to be in position as it was pre-op, immediate post-op, and it looked like it was a fairly simple revision, but the cup has migrated, the head has migrated so much more proximally, probably the poly is completely worn out. And that was the appearance on exposure, so much of metallosis, and the whole bone was eroded, and it was in thin shells and could not be reconstructed completely. So that is the part of the cup which has been completely eroded by the head, and the proximal coating also has rubbed off like sandpaper actually, and that's what has probably resulted in this extensive metallosis. Since we are not prepared completely with all the necessary implants, we had to find an alternative to do something at a second stage, so we left him with a spacer, left her with a spacer immediately, and had a CT done to assess the complete degree of bone loss. There was a lot of bone loss in the pubic bone as well as the ischium and the superior part of the acetabulum there. And finally, in the second stage, we did a reconstruction. There was hardly any bone in the proximal femur, but we got a good distal fitting restore stem and a cage with a reasonably good prosthesis, and the patient recovered well, and it's 4 months now and is doing pretty well walking around. On the right side, if you notice the right side also, there's an eccentric placement of the femoral head with a acetabular, superior acetabular lysis here, which was addressed in a next surgery, and bone grafting was done because the cup was very stable. The lytic area superior to the acetabulum was bone grafted, and a liner was cemented into the cup itself. Unfortunately, the problem of removing a liner, the clip which holds the liner had broken, and I couldn't there was no spare clip available on the table. So I had to cement a liner into it, and that resulted in a little bit of extra offset on that side, but the patient is comfortable and walking well now. Post-traumatic acetabular fractures, you have already heard it once, also can cause a lot of problems, and we need to be prepared with augments, cages, and bone graft in these kind of situations. Inflammatory arthritis results in a lot of acetabular bone destruction, which again needs to be addressed. And here we have a dysplastic hip with a trauma situation where we needed a separate kind of a problem with probably a little proximal migration of the proximal location of the acetabulum and the elevation of the center of the hip. Here we had an acetabular deficiency with femoral deficiency 7 years post-surgery. This is a kind of cup which I don't know which thing is that the screws were placed through the poly in the cup, and the whole thing was completely loose, but surprisingly it lasted for 7 years. So this was revised with a distal fitting stem, which is the SROM, and it was quite stable at surgery, and bone grafting was done for the acetabulum also. Cage reconstruction, one must remember, has its limitations, and the incidence of failure it ranges from 12.5 to 34% in literature. And you have a situation where we have reconstruction of the acetabulum by custom-made cages using 3D models, rapid prototyping. This can be done where you have facilities to do a rapid prototyping of the bones, and also to create a custom-made metal implant. What we need now to address some of these bone deficiencies, which we see very often, are custom design capabilities and a new material which has the strength of either stainless steel, chrome cobalt steel, or titanium, and capable of integrating into bone, incorporate cellular elements to hasten the bone, and with good tribological properties. I was involved in a couple of research projects, which I'll give you a brief outline about. The design process for custom-made implants is that you take DICOM images from the CT scan of the patient, convert them into STL files, which are recognized by 3D printers, and create a model, and which on the computer you can do a mesh modeling and a finite elemental analysis. You can design your prosthesis on the computer using some of the software. You can also analyze the biomechanics of the thing, including the whole gait patterns. And then you can create your custom-made prosthesis using a 3D printing technology. This is a patient who had a hemipelvectomy for a chondrosarcoma, and also proximal part of the femur was completely removed. He was quite comfortable walking with a dangling limb, but since he came and wanted something done, we experimented with his CT scans, and the people who wanted to create this prosthesis wanted to know exactly what they want, so I created a stainless steel mesh out of to show how the acetabulum should be positioned. And then we converted that into a model which was done using the 3D printing technology. And this is something a software which is available, which gives us exactly what are the stresses going through. You can apply various properties to the bones that you are experimenting on, and you can get this amount of stress that measure the stresses, and also look at where your fixation points have to be for your implant. The right hemipelvis was created out of a mirror image of the left hemipelvis, and a conceptual model was developed with the rapid prototyping. This is a model which is developed on the computer, and then it was converted into a plastic model. And a mesh model was done, and points of pressure measured on the ADAMS software, which mimics the gait of a patient, and you incorporate the properties of titanium or bone, and then it will give you the stress points where you can neutralize it by putting appropriate screws. And these were the stress points which were identified. The light blue one was an area where there was maximum stress here. And you can actually measure the forces acting across points of fixation in this particular software. And following the study done on this computer, the 3 points of fixation were pointed out on the proximal part of the thing, one on the L5 vertebral body. And then there was a point of high rise stress at the L5S1 junction, so there was a proposal to fuse the L5S1 anteriorly, and then there were 3 points on the opposite pubis which would neutralize it. All this was seen on a computer. The moment you put these fixation points, the stress areas on that became less. You can see the blue and red areas here. These are points of excess stress, and the blue area is a point of least stress. So with these, we could conceptualize where to fix the pelvis, where to fix it if you have to create an implant. Fortunately for us, the patient refused any surgery, so we didn't have to go to the next step. It was just a good experiment, learning experiment for us, because the thought of fixing the posterior part on the lumbar spine and the anterior part on the pubic bone, it was quite a challenging thought. But anyway, the patient didn't want any surgery because he had already had maybe about 8 surgeries for his chondrosarcoma, and he was used to walking on his dangling limb. The next issue we need to address is the material that we are using. Can we improve upon what material we are using? This again was a part of a small research project which I got involved in with a material scientist at the Indian Institute of Science. The material was expected to be biomechanically biocompatible as well as have the mechanical properties which suits our need. And the way to go probably from now on is composites. No single material is going to meet that criteria. So composite was the material that we go. There was a project with Dr. Basu, the material science professor at the Indian Institute of Science, who had developed this composite hydroxyapatite high-density polyethylene alumina, and this was converted into a acetabular cup. The cytotoxicity study was done in the Indian Institute of Science, and then the biocompatibility was done at the Sri Chitra Tirunal at Trivandrum. And the prototype was created by compression molding at the CPET, that is the Central Institute of Plastic Engineering and Technology at Chennai. And now it is undergoing a trial of wear properties at the CGCRI, which is the Central Glass and Ceramic Research Institute at Calcutta. The good part is that the linear test wear properties and the surface smoothness that the Acetabular cup prototype which has been created have been very encouraging, and we are awaiting results of the hip simulator tests before it can be taken to the next step. So these are the results of some of the tests which were done before it went on to making a prototype. This was placed in a rabbit thigh model, and histopathology of that done across the bone and the material used showed excellent integration. That was a very interesting thing, because this is a material which can integrate completely into the bone, and it has got good tribological properties. It can be molded by heat molding, as well as it can be put into a 3D printing technology where you can get a custom design processes. So the wish list for us would be have a material with good tribological properties which can osteointegrate on the outer surface and easily custom designable and capable of going through a 3D printing process. If we can get this, we will solve a lot of our acetabular revision problems with one single prosthesis rather than anything which will probably be more durable. Lessons I have learned with these few revisions and things that I have done is a CT scan is probably a must in all these cases of revision, where you'll understand the amount of defect there is in the bone and the actual size for templating X-rays, and be prepared for the worst. Always have bone grafting options and ensure the sizes of implants are available and a variety of implants available, if necessary, from more than one vendor. In fact, when I did the hip which was done, I had vendors from 4 different companies, Stryker, Zimmer, and Depew, and everybody was there with the implants required. So THR is definitely the surgery of the century, but revision is always a compromise. Thank you. Yes, sir.